Hi, everyone. Stewart Gandolf here, and glad to have you on today's podcast. Today, I'm going to interview an old friend of mine who has been a thought leader in healthcare for a long time. And I first met Lee when he was in charge of social media and a real innovator in social media at Cleveland Clinic. And actually,
Actually, it was Mayo Clinic.
man, did I say, oh my God, we're just talking about cleaning, so I flubbed already. We talked about scripts. We were just talking about Cleveland Clinic. So, and, and I do know that. And at Mayo, really, you guys were like kind of the founders of the whole movement. You guys gave the credibility for other hospitals to follow suit. It sounds crazy now, but back when you started, Lee, right?
Then it was scary, yeah, for some folks. And I think my role was I started at Mayo Clinic in public affairs on the media relations team in 2000, and then 2003 became manager of the media relations team, and then 2005 heard about this new thing called podcasting at the time, which had been invented a year before. And so that's when I used what I like to call the proceed until apprehended model of innovation. We had a 60-second radio segment that we were providing on a syndicated basis. And I said, wow, this is to create a podcast, all you need is an RSS feed connected to an audio file, a source of audio files. And this was about a month after Apple created its iTunes podcast directory. And so I said, how hard could it be? I got somebody from our web team to create an RSS feed, and we had the segments already on the website. And it was about 2 months later, I got a call from the technology commercialization group at Mayo saying, we got a request from this pharma company that wants to advertise in our podcast. Do we have a podcast?
And I never knew that. You never told me how this developed.
So I kind of had to backpedal, because all I had done was taking our existing resources that were already on the web, got the Mayo Clinic logo, put it in the iTunes podcast directory. And anyway, I went to look in the podcast directory in iTunes, and our podcast was on the front page. And then I went and looked at our server logs, and I found that our downloads had gone from 900 a month to 74,000 a month in 1 month. So this is like 2005. And so that caused us to take a step back and say, okay, this was not the ideal podcast. This is kind of the hypochondriac feed. So as opposed to our extended conversation and you having the topic all related, I mean, this was heart disease one day, cancer another day, it was sort of great for the mass audience, but not so much for the targeted focused audience. So we took a step back and looked at what would it take, what should we do with this new media? Because my main job was, dealing with New York Times, Washington Post, national TV, other regional TV and newspapers. And so it was hard to justify. So how much should we be spending on this versus what I was mainly supposed to be doing, which was the big media? But we came up with a strategy, and then we just sort of nudged our way into things over time. And then around 2009, just based on some of the success we'd seen with some of the YouTube videos we'd done and some of those other projects, I made the proposal to create the Mayo Clinic Center for Social Media as a way of, in keeping with how the Mayo brothers had done old-fashioned analog social networking in the 1920s, 1930s, visiting lots of countries when they had to go by ship and by airplane and train to get there. The fact that you could make these connections instantaneously with electronic tools, and you could broadcast with an FCC license, and how cool is that? So we got that approved, and I got to add 8 new members to our team and actually create a new team that was our social media team. And as a result of that, I got to travel to a dozen countries on 5 continents in probably 45 states. And essentially we were, as you said, it was a scary thing back then, because people would say, well, what about HIPAA? What about with social media when all this, well, what we could say was, when people are going on Facebook, they're putting their own information out there. It's not us doing it, so it's not like and so because I had the experience with getting people to sign releases for patient stories that we were pitching to traditional media. It was sort of a natural progression there. And then there were people, in other hospitals who were trying to get their leadership to say, they were saying, hey, we should have a Facebook page. And their leaders would say, well, that's stupid. Why would we want to do that? And then they'd say, well, Mayo Clinic is. And they'd go, oh, okay. And so that's why we created what we then called the Mayo Clinic Social Media Network, as a way to kind of monetize our leadership in a sense, but also to do the things we wanted to do. Like we wanted to be helpful to our colleagues who were looking for guidance and help and community. So that was a great time to get to do that. And we, in addition to annual conferences that we held at Mayo Clinic, we did 2 conferences in Australia and 1 in Dubai. And it was just a really great experience and really set the tone. And because I'm really grateful for that, because it set the tone for me to be able to do the thing that I'm doing now, which is I took early retirement from Mayo Clinic in August of 2021 to found a company called HELPCare LLC. And and this is in collaboration with a high school classmate of mine who's a primary care doctor. We had the idea of creating a direct primary care clinic in Austin, Minnesota, which is our hometown. And just sort of as our vision has evolved, we want to help. So 5 years ago in October, Dr. Dave Strobel and I got together for coffee, and he told me about this clinic where he was working that was owned by the Pipe Trades Union, and where he talked about like the union members don't have to pay for their office visits. They don't have to pay for their lab tests. If they go there for care, it's free. There's nothing out of pocket. And I said, wow, wouldn't that be cool if we could have something like that in Austin? But like where anybody could just buy a membership. You didn't have to belong to a particular union. I didn't know there was such a thing as DPC at the time. I had never even heard of it. But anyway, I went back to school to get my MBA in healthcare management online during that time, and then took that early retirement to found this company. And we're the management services company for Spark Health PLLC, which is a professional limited liability company, because as a non-physician, I can't own a medical practice, but my wife and I are the majority owners of the management services company, whose role is to let the doctors and other practitioners do their thing, and we take care of the membership acquisition and all the other business stuff, the administrative stuff, which is very much like the administrator-physician leadership partnership that we had at Mayo Clinic. So again, I learned a lot of lessons from my work at Mayo, and this has given me a chance to have a third career that, Lord willing, I hope will be another 20 years where I'm able to do this, and hoping for more impact in this than what I had in my last career.
That's great. Well, again, congratulations. I've known you for a long time. And yeah, I think it's hard for people that weren't on the healthcare, that are newer to healthcare now, to recognize how hard it was. We're interviewing Ed Bennett again. If you remember, Ed used to keep track of which hospitals had a Facebook page.
Yeah.
Eventually everybody had it, but that was the thing. Oh, we have 2 more. Like, it just wasn't my way. Hospitals are notoriously conservative, and doctors far more so. Yep. And so it really is some of Mayo. Like when we would work with clients, we would, you had, and I sent a couple of my people to your trainings, but it's like that, if Mayo does it, it must be okay. It's like, it was, very real.
We provided some air cover for folks, yeah.
But you know what we were talking before about, I'm going to jump to what you're doing with Direct Primary in just a sec, but I want to wrap that up. It's one thing about, because we were talking offline earlier about Cleveland, which is why I flubbed there, and then Mayo, those 2 respected institutions both look at themselves as leaders in healthcare. Like they really are at the forefront. They want to be pushing the envelope, which is a lot of hospitals don't feel like that at all, right? It's not their DNA, but it definitely, of all, Mayo is the respected one for that. But you took some little risk there doing that. I think there must be a little like that.
Yeah, it was. I mean, it was
a little feathers over there, but I think it's that you did it. We'll move on, but I'm just a lot.
Yeah, it was. There were definitely a few times when I had. Well, actually, there was one time when I was. I got a call from our department chair at the time, and he said, "Yeah, there's a lot of talk because crazy story. If you got a second, I was
I got a lot of time.
so a little bit how this. It was just, I mean, it's just kind of fun to relive because I had a talk with, so we had conjoined twins separated at Mayo Clinic. And as part of that, I got to really know a couple of the reporters from the Minneapolis Star Tribune who were covering it in an extended way. And one of them called me on a weekend, a Friday, and said, they said, you were talking about Twitter and you were using Twitter. And how do you even do that? Like, what's that even for? So this is back in like 2008. Okay.
Yeah.
And I said, well, I'm flying out. Actually, I'm flying to Baltimore. I had, met up with Ed Bennett back then. I was there speaking at a conference. I said, I can stop by on the way to the airport and we can, I can talk with you about it. And so I did, I did that and got back. And then I remember it was Good Friday. She sent me a direct message on Twitter saying, we'd like to do a story about you guys using social media at Mayo Clinic, and I'd like to follow you around for a day. I was saying, oh crap, now I got to find something interesting to do. And so it's like, so we decided to hold our first tweet camp. Then, so we had it was an hour-long, gathering where we got some of our public affairs staff together and a few doctors, and we just took them sort of through Twitter 101. Anyway, that was scheduled for the following Wednesday. On Monday, I believe it was over the weekend, Henry Ford Hospital had done the first Twitter surgery, like they were tweeting from the OR. And so Roger Serlo from ABC News was calling around to various outlets because the story had been on CNN and he wanted to do something on ABC about using social media in healthcare. And so the person who was on press call called me and said, so do we have anything? I said, well, we're doing tweet camp on Wednesday. And so on Wednesday, we had both the Minneapolis Star Tribune and a camera from ABC. And I think I got on ABC World News Tonight because of it as well. Anyway, the following week, I was out in Philadelphia for another conference, and I got a call from my department chair, and he said, yeah, there's a lot of talk about you being in the media and this, these stories and stuff. And I said, is it okay? He said, oh no, it's great. Because Mayo does want to be the leader. Okay. But we, at the same time, we have I speak we in the past tense, but we, as Mayo, there's this, well, the physicians are the leaders. The physicians are, and, we don't have a star system or anything like that. And so, but yet what happened with that, what helped me be able to do this well is that the external credibility helped the internal credibility. Because, if you are being recognized, if we're being recognized, I got a front page story in the Minneapolis Star Tribune in the business section with a picture of me. And so it's like, okay, now we're the leaders in this. And so that gave me a little bit of momentum that we could then apply toward kind of continuing to push the envelope.
Okay, so I'm going to pivot, but I just got to say one last comment to this. I love it, Lee, so much. I love that because, and it's funny, as our agency has grown, I have our account director, the person in charge of all of our client service, is fascinated with me because I've always been very scrappy as an agency. We've always just like, let's go over there, right? We just do it. And he comes from a much more buttoned up background, which is great. We need that too, right? We have a full page going on. So I love that because he loves the innovative side of me. I love the discipline side of him. But that was a lot. That's an even better story than I realized. And we talked about this a little, but that opening story, because it's really hard to relate to if you weren't around then, but it was very different. And you took those risks and you jumped on. It's like, oh, it must be okay. But if you'd asked, they probably would have said no. So,
right. Yeah. That's what I like to say. It's proceed until apprehended, which is the other way of saying, ask for forgiveness without permission. But if it works well, then you don't have to ask for forgiveness. So
I like that, proceed until apprehended. We'll have to remember that. I love it. Scrappiness, even at the Mayo Clinic. I can't believe it. So let's talk about direct to primary care. So you mentioned earlier you weren't familiar with it a few years ago, and I actually first became aware of direct to primary care when I was co-writing a book with Dr. Mark Tager, and we were writing about cash pay healthcare. And so
I've got that book.
I'm sorry. Oh, you do?
I've
Awesome.
got, yeah, exactly. Yeah.
You read our book. Tell her I didn't
Yeah.
know that. I should have asked you to sign for a forward backlist. I didn't even know. So I wrote that book with Mark, and that was the first time I'd heard of direct primary care, but I had to study it to speak to that because the book's broader than just CT, direct primary care. It's broader, but I'm intrigued by the model. And the reason I'm super excited that this is what you're doing. And by the way, I was bummed when you told me you were taking retirement. Like, no, I love it. And I was so excited to reconnect with you.
Yeah.
But so my own little story on this is beyond figuring out that this exists when I was writing my book and understanding the difference between primary care, between concierge care, which I'll come back to. Um, it's funny since you probably know, at least read the book and maybe you know Mark. I asked Mark, my wife is having, sort of menopausal, premenopausal stuff, which she's not embarrassed me to say. I actually wrote a book or wrote a blog post about sensitive marketing topics. So it's in my blog. But, so she said, I'm just not getting it with my primary care. And so Mark referred her to a cash pay only, not really direct to primary care, but a cash pay only functional integrative medicine doctor, an MD, but just sort of outside of the system. And so it's been really intriguing to watch, and she's better, she's doing great. And so, for all the tests, and in this case, all the tests and all the different things, she had to go to a cardiologist over here and a gynecologist over there and, do this and that. We did not under the insurance. So we just paid cash for her advice. She was like the quarterback unofficially. And we just, fortunately can afford to have her too. But let's get back to, so I love this model. And like I said, I've been aware of it for a while, but now I have a friend who's leading a clinic, which is I'll have to keep in touch with what you're doing. And I know some of the stuff we're going to talk about later is pretty innovative. Well, let's start off for our audience, some of them probably know this well, some probably don't. Just talk about the direct primary care model. First of all, contrast it perhaps with traditional, sort of a primary care in an HMO versus a concierge medicine versus, whatever. And particularly with concierge, where I think sometimes it gets confused, like some of the differences. But help us there to define.
Yeah. So, I mean, I guess I'll just say what our direct primary care model is. And I think we have kind of a special model of it, but it's, the big difference is that we don't take insurance. So there's no insurance payments. So because of that, we don't have to have three people like me fighting with insurance companies to get paid, and where you're jacking up the price and to negotiate it down. And there's all this cat and mouse kind of game being played. You're getting a relationship. You're getting a relationship with a practitioner, doctor, PA, or nurse practitioner, who and where you have unhurried appointments. So we have a maximum of 7 appointments per day. So instead of the 15-minute treadmill where you only have time to do, you have high cholesterol, we got to get you a statin. You have high blood pressure, let's get you something else for that. We're able to have our practitioners spend the time to get to know the patient and get to know what their preferences are and what they want to do, and are they willing to make some of the lifestyle changes that can actually be much more powerful in solving the problems instead of just a pill for this and a pill for that with conflicting side effects. So that the fundamental nature is that when you have the member paying for the membership, they are the boss. Like, they're the ones who are in charge, and it's not dictated by. Now, we deal with some pre-authorizations because people do have insurance still, so we can talk a little bit later about how that relates with it. But the majority of our members have either a MediShare or a Samaritan Ministries or some kind of health sharing plan, or they have insurance through their employer, or they maybe have an Obamacare exchange plan, but they just say, hey, this is the kind of care that I want to get. And one strategy that they might take is take a higher deductible and pay less for their insurance, and then hope, and believe that by being proactive with their health and getting good primary care, they can prevent the need to get, to be paying, retail prices through the big box insurance or big box, medical centers, and running it through the insurance. So that's really the fundamental essence. It provides predictable revenue for the practice because people are paying a monthly or annual membership. In our particular brand of it, we don't charge for office visits, and that's pretty normal. Sometimes you don't pay for phone visits, but you pay, I have a copay for an office visit. But we wanted to set it up that it would be no charge for office visits. And we do more than 100 lab tests as needed at no charge.
That's great.
So we have a group purchasing agreement where we can get the labs really affordably. So our price point, we've got a couple different price points, 3 different price points actually. We've got an acute care one, an acute care plus an annual physical with a dozen lab tests that would cost $1,000 in the insurance-based system for $99 a month. And then we're at $149 a month for what we call HELPCare Premier, which is it's mainly for people who have, repeated needs, things like they're managing thyroid medications or their type 2 diabetes, and we're working to help them get their medications adjusted. They need to see a practitioner more often on a scheduled basis versus just the acute. And so having those 3 levels enables us to meet people where they are, and we don't have it based on age. So a lot of direct primary care practices have 18 and under, 18 to 45, 45 to 64, and 65 and up. We don't do it based on that. We do it based on what the members' need is and what they perceive their need is going to be. And part of what we hope we'll do is some of them might start with Premier because they've got a lot of stuff to get sorted out. And if we get them after a year to a place where they could get by with an annual physical, then they can downshift to the middle tier, and it's win-win because then, we're helping them get healthier, which is sort of how novel is that we don't get paid more when we see them.
That's awesome. Yeah. So so people are probably more familiar with concierge medicine, and there's some similarities. Do you see any clear differentiations besides the fact that concierge is more expensive?
Yeah, I think that's the main thing. Is this is sort of like blue collar concierge medicine. It's kind of essentially what we're doing is giving people the Ritz-Carlton experience for the Holiday Inn price.
That's awesome.
Now that it's
yeah. What is can you share kind of the range of monthly fees that patients pay for either you guys or just generally for direct primary care?
Well, for us, we range from $39 a month for that acute version, the HELPCare Quick, to $149 is the current rate for the Premier, which is the top end. I think in a lot of direct primary care, you're going to see it in the $60 to $75, $80 a month range. But again, then they say, well, but we'll give you discounted lab tests, and part of what we want, our philosophy is we want people to not be afraid to go to the doctor. We want them to, because there's a lot of people that have a $5,000 deductible and they're functionally uninsured because they have the protection in case they get hospitalized, but it's all out of pocket. I'm just not going because it's going to be $250 for that one test. And so the fact that we can wrap it into the membership takes away that barrier to being seen.
That's fantastic. And from the doctor's point of view, I bet they love practice. The doctors that work with you guys.
They do. Yeah. I'm not going to say leisurely because they work hard. Okay. But it's not the hectic, how am I ever going to catch up on my notes because I'm seeing, 15 or 20 people per day and then having to do all the documentation around it. And not really feeling like they get to, have a human conversation and really relate to the patients.
So I've seen the American Academy of Family Practice write about this. Is this a big trend in primary care? Or do you see this as, it's been around for a little while, but is it exploding or is it just a kind of slow?
I think it's really growing significantly. If you go to dpcnation.org, that's got a mapper of DPC practices. And they say there that 250,000 people nationwide are getting their care this way, are getting primary care this way. And I think there are 1,000 or 1,500 or something like that. I don't know exactly how many. But I was just at the Free Market Medical Association conference in April. that was held in Oklahoma City. And direct primary care is especially in the self-funded health plan, level-funded health plan world, it really is the cornerstone, because it's having good primary care causes you to get not need as much specialty care, but B, then to not be already locked into a big hospital system that's going to be driving all the traffic to their own specialists. There's a chance to have a conversation about cost and quality and deciding, where you'd like to go.
So it's just a cool concept. Like I had I got switched to a drug because during COVID, I had asthma as a kid, but I go running them out. So I'm like, it's controlled, but they switched my drugs. And I had a new primary care doctor. My blood pressure was up, and then she's immediately telling me to go to statins. I'm like, wait. And my wife's like, what's new? And we're like, that new prescription. And when I called her, I said I did a telehealth. This is before she's ready. She's like, I know you're healthy and you're young, and not youngish, I guess. But yeah. But your blood pressure is high, and like you're probably just one of those people that has to, whatever reason. Like, well, I have this new medication I'm taking. Oh, well, that can't be it. Like, can you go check? Can you look? And it's just like, oh yeah, that one actually does cause high blood pressure. So I went off of it, and so lo and behold, I don't have high blood pressure anymore. But that's, most people don't have the ability to self-advocate, or they just assume what the doctor says. So I'd be on statins now. So but I think, and I, in fairness to her, I'm new to her, but she doesn't have the time to like really do that. So I would bet that same doctor might have been able to find out or dig a little deeper if she was under that constant pressure. Because to do it the way they're doing it, there's a lot, right? You've got the PAs and the NPs that handle the prescriptions, and you've got the scheduling and who's acute, who needs to come in right away. It can be an annual physical. There's a lot. So that's a very
there's protocols and guidelines, and they get paid based on their adherence to guidelines. And if they're seeing this situation, they're saying, well, I got to check the box because I only have 15 minutes or so. I'm going to check the box and say, well, I recommended the statin, because, and so that's going to be a lot of conversation. What's that?
It's defensive medicine too.
It is, yeah. It's that too, yeah.
So I'm not here to complain about it today. I've done it before in other podcasts, but not today. So,
it's not that.
Your doctors like it, your patients like it, probably insurance companies aren't thrilled. I want to talk about insurance in a moment because you have some cool models you're working with. But one argument I've heard about concierge more, which is there's some validity to it. It's like, wait, in a time of, staffing or, healthcare shortages, we're doing less patients, not more patients. So how does that impact the broader population? Do you have any thoughts on that for director of primary care? Because you can still see a lot of people, but I'm just curious.
Well, so, do you want to do a good job with them? I'll just say I got an email it'll be 2 years ago this October from someone who said, I'm frustrated enough with my experience as a provider in the healthcare system that I'm either going to need to quit medicine altogether or come work with you guys. So there's there's significant burnout among practitioners. And one of we did a radio program on the local radio station that we called Restoring the Soul of Healthcare. And that's really what we're about with this, is that we want to follow the Norman Rockwell meets the Jetsons model, where it's like the old-fashioned Norman Rockwell doctor's office, where you actually get to know your doctor knows you. It's a human relationship. And we use technology when it makes sense, that when it's an enabler, not a barrier that we say, oh, AI is going to cover everything. It's like, no, people want to really talk to, even if you think your AI is got good advice, you actually want to have a human relationship. And so I also, there's the think globally, act locally thing that, is the old saw. I'm big on, like, I'm going to try to solve the problems that I can deal with and try to be an influence and shine a light in the place where we are. And I'll let somebody else figure out what the geopolitical ramifications are for overall hospital, provider supply. If this is the way that, makes practitioners enthused about going to work and really engaged in that way, and that the patients like it. There are problems that are above my pay grade, and
I love it. I love
and
it.
I'm
Yeah,
not
it's not an
gonna
easy.
worry
That's
about
so
them.
me too. We can relate so often. Like back when I was starting doing what I do, and I used to work with a lot of providers. And look, I can't solve that. Nobody can. It's like you're holding me to an impossible standard. So another question then is, so um, I mentioned my wife earlier, and so we ended up paying for the full boat for primary care as well. And before we talked today, I was thinking, I wonder if there's a carve out now. If I said, okay, because there's still stuff like, what if they need an ablation? What if they need, or whatever? That's serious cost if you're paying out of pocket. So it's like, yeah, the high deductible is good for catastrophic, but things that are 3,000, 5,000, dollars, whatever, it's kind of a different category. Because for sure you'd want to have high deductible for the catastrophic stuff. But
Yeah,
I'm curious, like, well, wait, I'm saving if I committed just to going to you guys, and I wasn't using my plan for primary care, but I was using it for everything else, and that's where I think you guys are on the track for
I
this.
can personally vouch for how that works because, I had Mayo retiree insurance until just this year, and when it was finally starting to cost too much, and I think it was costing too much all along. But at any rate, I qualified for some tax credits through the Obamacare exchanges, and but I was able to compare plans, and I could get a $7,500 deductible with a $50 um, copay for primary care, or I could get a $3,200 deductible with a 50% coinsurance for primary care, which is in essence saying, okay, my primary care is over here. Okay. And so for about $50 a month more, I was able to get a $3,200 deductible instead of a $7,500 deductible. And so this is me on an individual basis with my wife being able to do that. But there are also some employer group plans that we're able to put together where, including direct primary care as that foundation, really can be one of several claim reduction strategies that are being used by, Health Rosetta type advisors to put together community health plans that are costing less and providing more care.
That's awesome. So, and I think you mentioned earlier, we were talking offline before we got started about having an insurance broker help put together plans. And so, do you see that as is this going to be more formalized? And because, like, you're smart enough to figure that out. Not everybody is. So, to put together plans and programs that would make sense. So it's like easy, like check the box, pick this option and that option versus trying to like get your mind around the whole thing.
Yeah, well, for the first year, we didn't have these plans, and so we were just growing retail, and we did have some employers who couldn't afford traditional insurance, but they wanted to provide some kind of health benefit, and so they could just go with our membership, and they weren't offering insurance. They were small enough that they weren't required to already, and they could just offer our membership as a way of getting most of the care for their employees. But it was about a year ago right now that I got in touch with some folks who have become really good friends, Colton Storla and Bernie Mackel and Skip Lowe from Northwest Partners, which is like probably the fourth biggest health insurance agency in the Midwest, at least in Minnesota. And they've got offices in a few different states, but they again use their Health Rosetta advisors, and they kind of break apart the BUCA type plans and have a third party administrator, transparent fiduciary, pharmacy benefit manager. They have some options for some other options for drug sourcing, and then referrals for tertiary, for at least for surgery and for imaging, to be able to get more competitive prices on those. And they develop new plans that so it's not as off the shelf as some of the others, but if you're paying off the shelf, you're getting the rack rate. You're not gonna get any deals that way. If you have a good claims year, they don't typically send you a refund. With some of these level funded plans, they actually do. They get refund checks if they've had a good claims year. And so there are definitely some cool opportunities. And that's what was part of, I was just at a conference sponsored by TPAC, which is a third stop loss carrier or a stop loss insurance group. So in these level funded plans, they set a rate. Not yet, but I will. Okay.
I will not go too long. I'm just too intrigued in this topic.
Okay. Yeah. So I will, if Kel, just a second, Lisa, I'm doing an interview, and if we can cut this part, but don't order it yet. Oh, okay. I went to order ours. Yeah. I've been asked about dinner plans and what I'm needing to order. So anyway,
I
was at this group and where
I'll get started again. I'll do about 10 more minutes. So this has been awesome. This is really fun. And we will cut this middle part. So where were we? What were we talking about?
Well, yeah, I was just talking. I attended a conference sponsored by TPAC, which is a Twin Cities based third party underwriter, where they help do the stop loss analysis, so that with these level funded plans, they set an amount that is what the not to exceed amount is. It's the monthly premium that the employer is going to pay, and then there's a claims fund that's part of that the third party administrator pays the claims out of. By having our membership as part of what gets paid out of that, we're not filing claims with the insurance companies, but also no claims for our services are hitting the pool. And if there's money left in the pool after 18 months, the employer gets a check back for that amount. But the stop loss, it's like the Lloyd's of London insurance on top, is like if somebody in your 10 employee group gets cancer, okay, then that's why you have the stop loss policy to prevent,
our agency, we have 40 people, and we got one employee, and of course they won't tell us when we don't want to know who, but had obvious health problems, and we had to go to the private market. We lost our PEO coverage for one employee, and that's with 40 employees. It's not that small, right?
Right.
So I can see how that would make a big difference. So we have to, before we, a couple more things I want to talk about. One is just the marketing side of it, because of course we're marketers, we enjoy communicating and marketing. So I'm curious about that, and then we'll finish up with just talking about the future and where you guys are going. So before I get to that, I would love, you are like the social media guy, and this certainly lends itself well to social media. But on the other hand, also, it feels pretty easy that you guys can reach out to major employers. This is a heck of a benefit. If you guys were close by, I'd try to figure out how to do this with my employees. Now, of course, we're virtual now, and half my employees are someplace else. But at any rate, though, if I was a local employer, I'd love to have this as
well, and actually we can do that. So we're part of a network called Hint Connect. So Hint is our membership management platform, and we can actually rent a network of direct primary care anywhere around the country. Others who are using Hint, and so we can develop a plan that has direct primary care as the foundation of it. So yeah, we're able to serve, we have employers who don't have all their employees in one place, and we can, kind of piece it together and be able to put together one that works overall.
That's amazing. How fun.
It's exciting. Yeah. It's stuff that wasn't possible, just a few years ago. And now it's, kind of feel like we're at the right place at the right time. Employers are going to be the biggest source of growth for us. We started out, the first year was all retail, and there was some employers, as I mentioned, the ones who couldn't afford insurance, but a lot of word of mouth, a lot of people telling their friends about the experience, and then geographically targeted Facebook posts. That's
for sure.
The ability for not that much money to be able to have content that people in your target market and target demographic are seeing. Is really positive. Doing some earned media stuff too, as we have new stuff. But
well, your guys' price point, we work with everybody from urgent care to addiction to, whatever on the provider side. And, with addiction, it could be $6,000 cost per patient. So that's make economic sense for you guys. But some targeted paid search and targeted social media, free and paid, you could do really well with that. But I feels to me, my instinct was the employers would be the place to go, because then it's not individual sales. It's like it's
Right.
a package, and particularly given the size of your operation, you can get pretty full pretty fast by talking to a few employers, I'm assuming, which is
Well, yeah. Well, one thing I, you know, highlight though is that we have practitioners who have contacted us who are interested in joining. You know, like
yeah.
they want to be part of this, and so part of what we got to do is match up the supply and the demand, and so we've got some good stuff happening and some opportunities for some new folks to start as of the first of the year. But we will have a big surge. We had a big surge. We had a good surge at the beginning of last year because of a couple employers signing up. We expect it's going to be significantly more this coming year.
That's fantastic. So, and to the extent that you're willing to share on a public forum here, like, what are your plans? Like, where do you guys want to go? It's exciting.
Yeah, well, so my goal is to be a service to other practitioners who don't have a friend who went back to get his MBA in healthcare management. Like they don't know how to they'd like to have a direct primary care clinic. They'd like to be the owner instead of being an employee. But they're not sure how to do it. And so that's my management services company is set up to do that too. And now that we've done it in a couple places in Austin and in Rochester, Minnesota, we do have a third location that's in the works right now. In fact, we just got our first founding member signing up this morning.
Awesome. Congratulations.
But so right now we're just taking deposits there. And then the plan will be when we get 300 people signed up, we'll be ready to open, and we'll be able to have a decent enough income for that practitioner owner to be able to operate with 300 patients, but looking at a panel size of 600 as the max, and you compare that to the couple thousand, 2,500, 3,000 that a lot of practices have in fee for service. It's definitely a much more personal. It's not exactly, I know forget his Dunbar's number, I think is the 150 is the number of people you can have a close relationship with. So it's 4 times Dunbar's number, and I think it's Dunbar, but it's still way more personal and more relational.
Yeah, that's great. So I did want to, before we wrap up here, you'd mentioned your challenge. So tell us about the challenge. That's really fun.
Yeah. So one of the things that we can only provide medical services right now to people in Minnesota because that's where our practitioners are licensed to, are part of the practices that we're serving. We hope to grow beyond that for sure. But HELPCare Challenge is a 13-week program that we developed where we provide, we do an in-body body composition test at the beginning and at the end, set of labs, a standard set of labs that would be like $1,000 in the regular healthcare system at the beginning, and then some of those labs also at the end. But things like A1C and fasting insulin and the thyroid panels, and as well as the lipid panels, and we give them a money back guarantee. 13 weeks. We've got weekly group sessions by a Zoom with a registered dietitian who lives in Washington State. But then individual sessions with her. And we do it based on our plan, which is called the Health, Energy, and Longevity Plan, HELP, which is the help in HELPCare. So I'd encourage people to go to healthcare.health and download it. It's free there for you to download, but it's a 10-point plan that my wife and I used to each lose about 50 pounds and get our health reclaimed over the last 5 years or so. And that's actually part of, those one of those streams that came together with meeting with Dr. Dave Strobel, my classmate, is that we recognize that the food pyramid is upside down. Okay.
Yeah.
That the 6 to 10 servings or 6 to 11 servings of bread, pasta, and grains that we've been told since the early 1980s has coincided with a tripling of obesity and a tripling of type 2 diabetes, and that flipping that upside down is a big part of helping people to reclaim their health. So we started out at first, we were doing the coaching, but as we've grown, I got to not do that. And so Jane, who's our dietitian in Washington State, does this. But anyway, we do beginning and after, for beginning and after measurements. And we just published a post earlier this week where the first 30 challenge participants who've done both all the beginning and ending figures, we've reduced fasting insulin by like 25%, insulin resistance as calculated by HOMA-IR by almost 35%. The average member, this is not a weight loss program. It's like getting healthy and then the weight loss comes over time. But in the 13 weeks, the average participant lost 11.5 pounds and 10.5 pounds of fat. Wow. Which is the key. Like like I said, it's not about weight loss, but you get going in the right direction and then you just keep going in that direction long enough and it reverses. So that's something that we're offering, kind of nationally, that anybody who wants to sign up for that could be part of. We have limited capacity for it, but that's something we'll be figuring out how we scale up as well. But it's when you recognize that, what we've been told for 30 years by the, and again, we could try to get the dietary guidelines changed. Yeah, that's beyond my pay grade, but what we can do is the folks we're working with, we can give them some guidance in how they can. And it's not just that, but some things like intermittent fasting, walking, sleep, the right kind of supplements that are things that are typically deficient for most people. So it's a 10-point plan. And if you go to healthcare.health/help, HELP, that's where you can sign up to download the plan for free. And if people take that and if they get healthy with it, with no involvement from us, we'll be delighted because it costs us nothing. And we just want to help people with that. But for the people who need medically supervised engagement in it, that's what we do here in Minnesota. And if they want some peer support, that's what we have HELPCare Challenge for.
Excellent. Oh, fine. Well, Lee, when I reached out to you, we hadn't talked for a while, and I'm like, I know he's up to something fun and interesting. So
it's
your time. It's good to connect again, and you have to keep me in touch and come back and share updates with us from time to time, because I'd love to see you be successful.
Thanks.
I think it's really, I know it's going to be just huge. So thank you for coming.
Glad to connect with you again, Stewart.
Awesome.